So one of the biggest challenges that's going to keep getting bigger is that as health systems buy private practices, health systems are coming at value-based care from a different perspective than a private practice may come at value-based care. In some markets, fee-for-service is still the king. And some of us believe that fee-for-service will always play some role in healthcare delivery, but it's going to have a diminishing role over time. So where CMS is talking about 50, 60, 70, 80% value-based care reimbursements or quality care reimbursed in this way in the next 2 or 3 years, we think that maybe it won't be quite that much, but that will happen over time. And so health systems in some markets are still fee-for-service based, and we have to work with that. Private groups are easier to work with in the sense that aspects of their business plan, such as admissions or readmissions or on-site radiologic studies or on-site laboratory studies, which oftentimes are more expensive than off-site studies, that isn't in their business model. So it's easier to work with that part of the whole total cost picture. So that's one aspect, but we have both groups. And then the third group that I didn't mention, but I was going to mention, but I'm going to mention right now, because it's a fascinating challenge, is you have employed physicians in large health systems. You have independent physicians, oftentimes in small town America. And then you have this third sphere, which is academic medicine. And how do we Venn diagram those three spheres of healthcare? That's the challenge that we all have. And how do we train med students, residents, and fellows on population health? That's my not my number one goal, but one of my number one goals, one of my top goals.